It's time for the 3-question warm-up for Cardiovascular 4. Let's get going. Where does each of the following spinal tracts decussate or cross over? First, we have the dorsal columns, and they're going to cross in the medulla after the nuclei. We have the lateral corticospinal tract, that's going to come down your cerebral peduncles and then cross at the medullary pyramids. And then we have the spinal thalamic tract, and this is going to cross over at the anterior white commissure, about 3 segments above the origination of the region of the innervation. Next question. What drugs are known for inhibiting cytochrome P450? So we have a nice mnemonic that we'll use throughout this course, and this is crack amigos. So C is for Cipro, the R is for ritonavir, that's a protease inhibitor. The amiodarone is for the A, C is cimetidine, K is ketoconazole, A is for acute alcohol use, M is for macrolides, I is for isoniazid, G is for grapefruit juice, O is for omeprazole, and S is for sulfonamides. Next question. What is a disulfiram-like reaction? What drugs cause a disulfiram-like reaction? So a disulfiram-like reaction is where you have an inhibition of acetaldehyde dehydrogenase. So alcohol can't be fully metabolized. So you have accumulation of aldehyde, and that causes flushing, sweating, nausea, headache, and even hypotension. And then the drugs that can cause it include metronidazole, that's one of the big ones, certain cephalosporins like cefotetan, cefamidol, and cefoperazone. And then we have the first generation sulfonylureas like tolbutamide, but we don't use those much at all. All right, so that's going to be it for the 3-question warm-up. Let's get to that lecture now.
In this video, we're going to talk about the physiology of congestive heart failure, or CHF. Now, if you think about the heart's #1 job as being to pump blood, heart failure is essentially pump failure. What happens when a pump fails? Well, the pressure going forward drops way down because the pump isn't pushing that fluid forward like it's supposed to. And then the pressure rises in the system that's feeding into the pump because that fluid's just getting backed up, right? So the left ventricle is the workhorse for pumping blood out to the body. And if the left ventricle starts to fail, the blood is then going to back up into the left atrium, and the left atrial pressure is going to rise. So let's start out by talking about the pressures in the heart. We use something called the pulmonary capillary wedge pressure, or just the wedge pressure, to estimate the pressure in the left atrium. So how do we measure a wedge pressure? Well, it's an important number, but where do we get it? You measure it with a Swan-Ganz catheter. Great, what's that? You may have heard of a Swan-Ganz catheter, but you might not really know what it is. A Swan-Ganz catheter is a venous catheter that's put into either the internal jugular vein or the subclavian vein. The catheter is wired through the superior vena cava and then into the right atrium, and it continues through the right ventricle. Now, there's a little balloon on the end of the catheter, and when you inflate the balloon, it kind of drifts along with the blood flow circulating through the heart, and the balloon and the catheter float down through the heart. So this inflated balloon goes from the right atrium to the right ventricle and then into the pulmonary artery. In the pulmonary artery, it continues until it can't go any farther. At the point where it stops, it's been wedged in one of the small branches of the pulmonary artery. At that point, you have what we call a pulmonary capillary wedge pressure. You've wedged that balloon into a branch of the pulmonary artery. The Swan-Ganz catheter then has a pressure sensing device in the tip, just beyond the balloon, so that when the balloon's inflated, you're able to measure the pressure distal to the balloon. Now that pressure is not coming from the right side of the heart because the balloon's inflated and you've blocked the right side of the heart from contributing anything to that pressure that you're measuring. You basically created a little balloon embolus with the Swan-Ganz catheter. So what pressure are you measuring just distal to the balloon? Well, you're measuring the pressure in the left atrium, basically. The wedge pressure is an approximation of the left atrial pressure, which is generally also a good approximation of the left ventricular diastolic pressure. Now, a normal wedge pressure is less than 12. And the left atrial pressure is less than 12. And the left ventricular diastolic pressure is around 10. So if you want to know what's going on the left side of the heart, you're going to use a Swan-Ganz catheter to measure the pulmonary capillary wedge pressure to make that determination. Now, in mitral stenosis, the wedge pressure is higher than the left ventricular diastolic pressure. Think about it. The mitral valve is stenosed or narrowed. So during diastole, when the mitral valve should be open, the left atrium is contracting. The left atrium is contracting against a partially closed valve. So the pressure inside the atrium is going to rise. Blood has nowhere to go, so the pressure rises in the atrium. And since the wedge pressure is roughly equal to the left atrial pressure, that wedge pressure is going to rise also. And the wedge pressure will be higher than the left ventricular diastolic pressure. Let's talk about heart failure next. Heart failure is not a disease in and of itself. Heart failure is a clinical syndrome. It's a constellation of signs and symptoms that you find in patients with abnormal cardiac structure or abnormal cardiac function. So it can be an acquired abnormality, such as ischemic heart disease or toxic damage from drugs or myocarditis, or it can be an inherited disorder. But regardless of the underlying cause, heart failure patients have this syndrome of findings including things like exercise intolerance and fatigue, shortness of breath, pulmonary ralls or crackles when you listen to the chest, and then also peripheral edema. So where do all these signs and symptoms come from? Let's look at number 4 in your study guide. There's a ton of stuff going on in this diagram, so let's go through this step by step. You start out at the left with a decreased left ventricular contractility. That's pump failure. You have pump failure because the heart's not contracting as efficiently. And what causes decreased left ventricular contractility? Well, the two most common causes are chronic hypertension and ischemic heart disease, including myocardial infarction. We call that ischemic cardiomyopathy. But chronic hypertension is probably the most common cause. Chronic hypertension leads to left ventricular hypertrophy because the left ventricle has to work harder to pump blood against all that pressure. So the myocardium becomes thicker and becomes hypertrophied. And left ventricular hypertrophy then becomes heart failure. So you start out with decreased left ventricular contractility, which causes two things: decreased cardiac output and pulmonary venous congestion. We're going to come back to that one. Let's focus on cardiac output for a moment. Low cardiac output is going to decrease your blood pressure. That makes sense. And the body wants to counteract that. It wants to compensate for that low cardiac output. The body's main goal is to get the cardiac output back up somewhat. That's what we see in the top right. The body's trying to compensate for low cardiac output by doing whatever it can to increase cardiac output. So keep that goal in mind. So how can the body compensate for low cardiac output? Well, there are two main ways: by activating the sympathetic nervous system and by activating the renin-angiotensin-aldosterone system. And it's not one or the other, you know. The body's going to do both of these. And we'll see that both of these compensatory mechanisms work. They do get the cardiac output back up somewhat, but they also have negative consequences, as we're going to see. So let's look at sympathetic activation first, following along that top row. You have decreased cardiac output, and that activated the sympathetic nervous system. This is a short-term mechanism to regulate the blood pressure. The carotid sinus senses that pressure is decreasing, and it increases its sympathetic outflow, which increases left ventricular contractility, which is a good thing. That's going to increase cardiac output, but again, that's sort of a short-term fix. The other big compensatory mechanism is to activate the renin-angiotensin-aldosterone system. Let's pause our discussion of CHF for just a moment and talk about this. It starts with renin, which is made in the kidneys. There are several things that stimulate renin production. One is the sympathetic nervous system, stimulating beta-1 receptors on the kidneys, and that tells the kidneys to secrete more renin. We see that on this diagram. The dashed line shows that the sympathetic activation also activates the renin-angiotensin-aldosterone system. A second way to stimulate renin production is that the macula densa cells in the kidney can sense reduced sodium in the glomerular filtrate. And the third way, which is the important one for us right now, talking about CHF and decreased cardiac output, the third one is the juxtaglomerular apparatus in the kidney, which senses the blood pressure. So when the JG apparatus senses low blood pressure, it tells the kidney to secrete more renin. Then, what does renin do? Renin is an enzyme that cleaves angiotensinogen into angiotensin 1. Then we need to convert angiotensin 1 into angiotensin 2. What's the enzyme that does that? It's angiotensin converting enzyme, which is produced in the lungs as well as in the kidneys. So we've already seen 3 different organs involved in the renin-angiotensin-aldosterone system: the kidneys making renin, the liver making angiotensin, and the lungs making angiotensin converting enzyme. Then we have angiotensin 2, which has several actions, but the 2 most important are: first, angiotensin tenses angios. It's a vasoconstrictor. It's the most potent vasoconstrictor in the human body. It acts on the angiotensin 2 receptors on vascular smooth muscle, causing vasoconstriction, and that raises the blood pressure. The second important action of angiotensin 2 is that it stimulates the adrenal glands to secrete aldosterone from the adrenal cortex in the zona glomerulosa. So that's a 4th organ involved here, the adrenal gland making aldosterone. And the downstream effect of aldosterone is that it stimulates the reabsorption of sodium and water in the kidney. So those are the main things with angiotensin and its downstream effects. It's directly raising the blood pressure through vasoconstriction, and it's also indirectly raising the blood pressure by expanding the intravascular volume through secretion of aldosterone and increased sodium and water retention. That's more of a long-term response to low blood pressure. So anyway, going back to CHF, going back to our diagram, we said that decreased LV contractility causes decreased cardiac output, and then decreased cardiac output with low blood pressure is It's going to stimulate the renin-angiotensin-aldosterone system, so you retain sodium and water, and that increases your systemic venous pressure and increases preload, which is going to help increase cardiac output. So again, the body's doing all this in an effort to compensate for the LV dysfunction. That's what you want to happen. Unfortunately, the increased fluid and the increased venous pressure is also going to lead to peripheral edema. So the box at the top right, increased cardiac output, that's the positive effect that we're trying to achieve. The other two boxes in the bottom right are negative, unintended consequences of these compensatory mechanisms. That peripheral edema is sort of an unfortunate side effect. Going back to the far left, we said that decreased LV contractility has two effects. We just looked at decreased cardiac output. Remember, pump failure affects the fluid going forward, so you have decreased cardiac output, but it also affects the fluid coming in. We said that decreased LV contractility will cause pulmonary venous congestion down there in the bottom fork of the diagram. The blood just backs up from the left ventricle into the pulmonary veins, which is going to result in a decreased right ventricular output. So decreased LV contractility leads to decreased RV output. Now, I'm sure you've heard this before. What's the most common cause of right-sided heart failure? Left-sided heart failure. You're going to hear that again and again and again throughout your training. With left-sided heart failure, you end up increasing the afterload on the right side of the heart as you congest the pulmonary vasculature. And then that contributes to the peripheral edema because systemic venous pressure is higher and the fluid in the venous system backs up and weeps out of the circulation into the tissues. But the pulmonary congestion and the left-sided heart failure also cause pulmonary edema. So there are two broad categories of CHF symptoms and two different types of heart failure. There's left-sided heart failure, which causes pulmonary edema and ralls and dyspnea. And there's right-sided heart failure, which we said usually comes from left-sided heart failure, but right-sided heart failure has a totally different constellation of symptoms. That's more of the peripheral symptoms like peripheral edema. So let's talk about the various signs and symptoms of heart failure and what causes them. We're going to start with left-sided heart failure and that pulmonary vascular congestion. So this can cause dyspnea, or shortness of breath with exertion, because the left ventricle output fails to increase during exercise. So, of course, that fluid is going to back up into the pulmonary vasculature, and you have dyspnea on exertion. You're commonly going to see that abbreviated DOE, dyspnea on exertion. Left-sided heart failure can also cause cardiac dilation because you have a greater ventricular end diastolic volume. So the heart's just going to get bigger and bigger over time, like blowing up a balloon. Left-sided heart failure can also lead to pulmonary edema, as we discussed. And you can have paroxysmal nocturnal dyspnea, where the patient wakes up at night gasping for breath, and orthopnea, where the patient gets short of breath when lying down, but then it gets better when the patient sits up. So all those symptoms are due to left-sided heart failure. So whenever you hear pulmonary symptoms in a heart failure patient, think about left-sided heart failure. Now, what about right-sided heart failure? Well, we mentioned peripheral edema. So there's pedal edema, which is edema in the ankles and the legs and the feet. That's what pedal means, feet. Now, there's presacral edema, where you press on the skin overlying the sacrum and you can kind of make a nice thumbprint because of pitting edema over there. You basically have increased venous pressure, which means that there's more back pressure on the capillaries and more leakage of fluid out of the capillaries into the interstitium. You can see jugular venous distension in the neck because of increased central venous pressure. And then right-sided failure can also cause hepatic congestion. So if the right side of the heart fails, blood's going to back up into the IVC, that backs up into the liver, and you get congestion of the liver, hepatic congestion, and hepatomegaly, or an enlargement of the liver. Now on biopsy or autopsy, the liver's going to look mottled. It looks something like a nutmeg seed, which you've probably never seen, but they call this nutmeg liver. So chronic passive congestion of the liver due to right-sided heart failure gives this nutmeg liver appearance. One other thing I want to mention briefly as we're talking about the signs and symptoms of heart failure is a lab test that's often useful, which is called BNP. BNP stands for either B-type natriuretic peptide, or sometimes it's called brain natriuretic peptide. So BNP is a hormone that's produced in the cells of the cardiac ventricles in response to ventricular stretch. And it does two things. It causes some vasodilation, and it's also a natriuretic peptide. It causes increased excretion of sodium and water in the urine. So it's a diuretic hormone. So when the left ventricle is failing and the end diastolic volume rises and the ventricles start to stretch, those myocytes start to secrete a little BNP. And the BNP causes a little diuresis and a little vasodilation. And both of those effects are going to lower the preload and take some of the strain off the heart. Now, we can actually measure serum levels of BNP in order to help diagnose CHF. So say a patient comes into the emergency room short of breath, and he has a history of both CHF and COPD. So you've got to make a solid diagnosis so you can treat the patient appropriately. Does this patient need albuterol for COPD? Well, that's going to make the heart work harder. Or does it need to be treated for CHF? So it's extremely important to be able to make the correct diagnosis. Or maybe you look at the chest x-ray and it's kind of hazy and you're not sure if he has some pulmonary edema from CHF, or maybe that's just actually an atypical interstitial pneumonia. So you've got to be able to make a correct diagnosis. So in addition to taking a careful history and doing a good physical exam, one test you can order is a serum BNP level. So if the BNP is elevated, usually we say above 100, then you know that this is probably acute CHF. So BNP might show up on your exam as a lab result that they give you in order to steer you toward one diagnosis or another. All right, that's it for right now. We're going to talk about how we treat CHF in the next video. But first, let's do the end of session quiz. First question, what are the signs of right-sided heart failure? So remember, right-sided heart failure is going to have all those peripheral signs and symptoms like lower extremity edema, jugular venous distension, maybe some hepatosplenomegaly, or nutmeg liver. Next question, what are the signs of left-sided heart failure? So left-sided heart failure is going to cause pulmonary symptoms like dyspnea on exertion, orthopnea, paroxysmal nocturnal dyspnea, and possibly pulmonary edema and Ralls on exam. And the last question, how does poor cardiac output result in an increase in aldosterone? So decreased cardiac output leads to low blood pressure, which is going to be detected by the juxtaglomerular cells of the kidney. And then those cells secrete renin, which activates the renin-angiotensin-aldosterone system and ultimately increases aldosterone levels. All right, that's it for Cardiovascular 4. I'll see you next time.